We'd also ask that you please complete the online satisfaction survey after this webinar. You'll be getting an email from Zoom soon after the conclusion of the webinar, and we ask that you complete that. As I'll speak about in a minute, this is the first in a series of policy forums that we're hosting, so we'd be interested in your input on future topics, as well as how we can move forward and maximize the impact of these forums. Oliver, next slide, please. So just a quick few but important acknowledgements. The support for this event is provided by the Robert Wood Johnson Foundation. The views expressed here do not necessarily reflect those of the foundation. We'd also like to thank our colleagues, Oliver Lontock, with whom, from whom you've received a number of emails and correspondence, Bram Poquet and John Palatucci, colleagues from the Center for State Health Policy, for their efforts in planning and executing this virtual forum. It really exceeded our expectations. We have 130 participants who have registered, so that's terrific across all sectors, and we're delighted, and I think we've picked on the right topic to kick off our forum series. And finally, I also just want to warmly thank our panelists in advance, friends and colleagues with whom we've worked for many years, for sharing their expertise and insights, and again, all of you for participating this morning in the conversation. So Oliver, next slide, please. Quickly about the Center for State Health Policy. I think many of you are familiar with the center. We were launched in 1999 with core support from the Robert Wood Johnson Foundation. We are a translational health policy center, and our mission is to inform and support and stimulate sound and creative health policy in New Jersey, really bringing evidence to bear to inform policy making. Currently, our portfolio focuses on the 5 core areas of research, so health system performance improvement, healthcare access, or access to care and coverage, and I think that's the lane this topic squarely fits in. Population health, and then health and long-term care workforce and long-term services and supports. Oliver, next slide, please. The goal of the Policy Forum series is really twofold. We want to address the most critical health and healthcare policy issues impacted by the COVID-19 pandemic in New Jersey, and draw on timely and relevant data and expert discussion to think about policy strategies to address both short and long-term challenges. I think we're all disabused of the fact that, you know, this is going to be, there are quick fixes here. We're in this for the long haul, and certainly Carl's going to talk about that a little bit of the long-term implications here. And you go through an experience like this when everybody has pulled together, and sometimes you feel helpless and you think about what others can do, and Joel and I said, well, what can we do? What do we bring to the table as a health policy center? And hopefully we feel these forums can be helpful and instructive in having good conversations. So hopefully in some small way we're doing our part. Topics under consideration for future forums, you'll see them there. Thinking about the impact on substance misuse and treatment, we heard anecdotally that the numbers of opioid overdose have been pretty startling over the last month or so. So impact of people who are struggling with addiction, the future of telehealth and what's next for the healthcare workforce, thinking about licensing issues and things we've learned over the last 4 months, mitigating the pandemic's impact on mental health, certainly related to the first bullet on mental health and, on substance use and people struggling with addiction. And finally, one of the other topics is addressing the health-related social needs such as food and housing insecurity. I'd remind you again, you'll be receiving a link for a survey at the end of this webinar, and there'll be an opportunity as well for you to nominate other topics that you think would be ripe for conversation over the next 6 or 9 months. Oliver, can you advance? Thanks. Quickly, the agenda for the next 90 minutes, and we are committed to getting you concluding on time. I'll do some introductions of my colleagues, the panelists, and then I'll turn it over to Carl, and Carl Van Horn will provide an overview of state and national economic outlook. It's a little bleak, but it's something that I think will serve as the context for the conversation that we're going to have later in the webinar, and I think Carl's going to touch upon really specific focus and impact on small employers. And then we're going to open it up for policy, we're going to provide a snapshot of some data on where we are in the small group market, and Joel will run through a few data slides, and then open it up for the policy discussion with our colleagues, the panelists. These are some of the topics that I'm sure we're going to touch on. Certainly the elephant in the room is addressing affordability in the small group market, opportunities and limitations of the individual market, and how these two markets are working together. We're seeing a migration from small group into individual. Is that a good thing? What are the trade-offs? Thinking about the alternative markets. So we're going to touch on PEOs, MIWAs, looking at the self-insured market and some of the challenges and trade-offs there with regulatory oversight. And then to think about how all this fits in with the introduction and implementation of a New Jersey state-based exchange, and where are the opportunities there, perhaps for some relief with the small group market. Again, I'm sure we're going to touch on a number of other things. We realize we can't boil the ocean in 90 minutes, but I think these are certainly topics that resonate to the top. We'll, again, encourage you please to use the Q&A box for questions, and we'll get through as many as we can and do any necessary follow-up. At the end of the slide, we have additional resources that we'll encourage you to take a look at based on the conversation we have today. So let me just do a few introductions, and then I'll hand it off to Carl. So here are our panelists, and a warm welcome to them again. First, we have Chrissy Buteas, who's the Chief Government Affairs Officer of the New Jersey Business and Industry Association. And prior to joining NJBIA, Chrissy served as the President and the CEO of the Home Care and Hospice Association of New Jersey, representing health agencies and hospice organizations around the state. Most recently, Chrissy has served in 2018 on the healthcare subcommittee team for the Murphy-Oliver transition. We welcome our colleague Peter Newell from New York. Peter is a health insurance project director at the United Hospital Fund, and prior to joining the fund in 2007, he had a long tenure as the executive director of the New York State Assembly Committee on Insurance. So Peter has certainly toiled in the bowels of legislation and understands how the sausage is made. So we appreciate his perspectives from New York. Our colleague, known to I'm sure all of us, Ward Sanders, is president of the New Jersey Association of Health Plans, and the association represents all the HMOs in New Jersey, including the 5 Medicaid plans. Prior to joining NJAHP in 2006, I can't believe it's been 14 years, Ward. Ward had previously served 15 years in state government, including as a DAG in the AG's office, and certainly in the position we're familiar with when he was the executive director of the individual and the small employer group boards. Most recently, he was appointed by Governor Murphy to the state's Restart and Recovery Council's Healthcare Committee, so a formidable work ahead of him in that position. Our colleague Linda Schwimmer is president and the CEO of the New Jersey Healthcare Quality Institute, and under Linda's leadership, the Institute focuses on collaboration and innovation to accelerate policies that make healthcare more affordable, transparent, and equitable. Linda also leads Senator Vitale's working group on health reform in the response to the ACA. And full disclosure, I'm a member of that working group and have worked closely with Linda. The Quality Institute, addressing the issues of the small group market, which obviously has been struggling over the last decade or so, has really been a focus of the QI's work over the last year intensively. And I would encourage you to look at the white paper that the Quality Institute released a week ago, and we circulated that in the invitations that we shared for this meeting. We'll be pulling, it's a great overview, and we'll be pulling some of the data and talking about it this morning. And finally, last but certainly not least, is our colleague and friend from the Heldrick Center at Rutgers. Carl Van Horn is a distinguished professor of public policy at the Blaustein School here at Rutgers, and he is the founding director of the John J. Heldrick Center for Workforce Development. He's a widely recognized expert on workforce, human resources, and employment policy issues, and he's also a senior advisor for strategy and planning for Governor Murphy. So I'll stop there. Again, welcome to and thanks to all of our panelists. And Oliver, I'll turn it over to Carl if you can bring his slides up, please. Thank you.
Good morning,
Carl,
everyone. Good morning, and thank you very much for inviting me. I have great respect for the Center for State Health Policy, and although I'm not a healthcare expert, certainly I am interested in giving you some perspective on what's happening to the economy. As Margaret already suggested, it's not going to be a happy story. I'm sure you would expect that, but I try to give you some perspective on as how it compares to the Great Recession. And it turns out that I was asked by the Federal Reserve Bank to write an article comparing the Great Recession with the current pandemic-driven recession. And so my comments are based on that. And as with the disclosure that was given about the Robert Wood Johnson Foundation, my views do not represent those of the Federal Reserve Bank. They are my own, but I am a visiting scholar with the Federal Reserve Bank, but not on the staff of the Federal Reserve Bank. So therefore, I'm an independent observer. So if you can show the next slide, please. I'm just going to go through these in the 8 to 10 minutes to give you a background. The slides will be available as well as the full article that I referenced. So if we go to the next slide, this is really the story about job and healthcare insurance losses in New Jersey. 1.3 million people applied for unemployment insurance between March and the end of June. That's 1/4, slightly more than a quarter of the state's labor market. Private sector employment declined year over year by 660,000. That's 18.5%. But as you can see, the number of industries lost huge numbers: leisure, hospitality, including healthcare and social insurance. The estimates from that I looked up was that the non-elderly adults lost 124,000 job coverage in insurance from 2018. And based on a survey that the Eldridge Center had done for Governor Murphy, a number of businesses who are going to cut employee benefits have decided to reduce healthcare insurance for their employees in response to the fiscal pressures that they're facing. Next slide, please. So this just gives you an idea and perspective before the recession, which is the line on the left that looks very flat. Less than 3 in 100 New Jerseyans were applying for unemployment insurance on a regular basis. And then beginning in the middle of March and ending up into May, it was 12.2%. So there's a huge increase in the per capita increase in people applying for unemployment insurance. Next slide. By late May, the labor market in the United States had shed 40 million jobs. That's more than all of the jobs gained during the last decade plus since the Great Recession. So the initial depth and scope and workforce damage is much greater this time than before. The unemployment top line number went from 3.5% to 14.7% in May. And again, that's more than the 10% reached at the worst period in the Great Recession. Next slide. As I'm sure you know, but just to underline it, this particular recession is causing far greater harm to minorities and low-wage earners. This is true, happened also in the Great Recession. New Jersey, unfortunately, is even worse than the country when you look at the overall profile. The percent of change in employment among low-income workers is minus 42.4% in New Jersey versus the country, which is 37%. Next, please. There are some positive signs as economy in New Jersey and around the country began to open a little bit, especially because employers were beginning to bring back furloughed workers. But U.S. employment added these 5 million jobs from May to June, but our next window on this will come up what happened in July. Beginning in the very early part of August, we'll get those numbers. And unfortunately, we're probably going to see a partial reversal of that good fortune because of the continuing scourge of the pandemic and the effect it's had on the repurposing and reclosing of state business activities around the country, especially in the southern states, but also in California. Next. So the bottom line is the recovery from this is not going to be what some people refer to as a sharp V-curve recovery, which we've had in other cases. It is going to be very slow in the same way that the Great Recession took over 10 years to recover back to what it had been before that. It probably will take longer in most economists' prediction than the Great Recession. The Congressional Budget Office, for example, projects that U.S. unemployment will still be above 8% through all of 2022. and the GDP will not return to its pre-COVID trajectory for several years. The Federal Reserve has a fairly similar estimate. These estimates, point estimates, of course, are subject to the revolving and evolving changes of state economies as they respond to the healthcare realities. Next, please. The monetary and fiscal responses of the government were very similar initially in the sense that they were bipartisan and they were very large and they were very swift. The 4 bills, recovery bills that were passed by the Congress and signed by the President related to the pandemic were more than twice the amount that had been provided during the Great Recession. The Federal Reserve actions were also very similar. However, this time they added the Paycheck Protection Program, and also unemployment insurance benefits were enhanced significantly this time around. However, both of those are either out of money or set to expire actually next week for unemployment insurance enhancements. So of course, if they do, then that means people will have less money to spend, and that will of course further challenge the economy. Next, please. So in short, the traditional strategies that we've used in this country to respond to recessions probably won't be sufficient this time. Obviously, we've already spent twice as much at least trying to respond to this, and that will not yield to those investments immediately. And so the continued spending from the federal government is absolutely essential. I would commend to you, for example, an article, an op-ed piece by former chairman of the Federal Reserve, Ben Bernanke, in yesterday's New York Times, in which he explains why it is essential to continue to do this. I think all of the folks on this call probably know that the federal government is the only governmental entity that has the ability to borrow, in a sense, almost unlimited amounts of money in order to deal with the crisis that we have. We are fortunate in that our financial institutions in general, private financial institutions, are in relatively good condition compared to the Great Recession. We also have the continuing drag on the fact that most Americans in all the surveys that I've reviewed are still very reluctant to return to traditional activities, and I think for very good reason, such as eating out and traveling by air and rail, going to large events. And so we're going to experience a lot of businesses going out of business due to bankruptcy. And timing accurate responses, even if they're quick, is extremely difficult in relationship to the current crisis, at least until better remedies to treat the disease and of course prevent it from occurring are on the scene. And none of us knows, of course, sitting here today, how quickly that will happen. Next. So what happens now? Unfortunately, the bipartisan agreement that was in place briefly in the early spring has now crumbled. And it's going to be further challenged by the election as the Republicans and Democrats stake out very different positions. My guess would be, at best guess, that there will be perhaps one additional bill passed by the Congress and signed by the President before the election. And that's an optimistic projection. I hope that's true. But after the election, it's essential they find a way to go back to the bipartisan consensus they had before, because if they don't, this recession will be far worse than the previous one, and we'll be talking about this, and our children and grandchildren will be talking about this decades from now. So I was previewed as not telling a good story, but it's the best story that can be told right now, and it's best that we be prepared for this difficult time ahead of us, and hope that our national leaders are in a position to support the states and the people in our communities as they attempt to recover from this terrible disease and the economic catastrophe that it's caused. I'm happy to take any questions or comments. And again, I encourage you to write to me afterward if you'd like to dialogue with me directly.
Thank you so much, Carl. This is Joel Cantor, Director of the Center. Just to remind folks, if you'd like to submit questions, mouse over the bottom of your screen where it says Q&A, open that up, and we'll get those questions. I will start with one, and that is, of course, this is a terribly sobering assessment, Carl, and not unexpected, but the details do matter. Is there, given what we know now, is there anything you can say about how these forces are affecting that smallest category of businesses? And in this case, the threshold is 50 below and below. That's what drives the insurance market we're here to talk about today. Anything you can extrapolate from the data you're looking at for what's going on in that segment of the employment market?
Yes, of course. I mean, it is extremely difficult, as I alluded to before, because most of those small businesses do not have either personal reserves or access to capital to weather these sorts of difficulties. Because a lot of the collateral they have, if you will, is themselves, and perhaps they own a building which they've already undoubtedly mortgaged. So it's very difficult for them to deal with this. I mean, one of the references on the slide that's up right now is to a survey that we did of businesses in New Jersey. Roughly 3,800 businesses responded. These are decision makers in those businesses. It was predominantly small businesses with less than 10 employees, and half of the respondents were women and minority-owned businesses. I want to point out, so I don't lose my license as an academic, that this was a convenience sample, which means it's not projectable or representative of the entire population of businesses in the state. But to get that, you can also go to the US Census. They do regular surveys of businesses. But in any case, both of those show that small and medium-sized businesses have already been and will continue to be significantly affected because essentially they just don't have the reserves. Also, many of them do not have the capacity to work remotely or online, or their employees don't. They're in-person businesses, which is obviously very difficult. And you look at the restaurant industry, open, close, open, close. I mean, these are catastrophic for those businesses. So there are going to be fewer of them. And even if they were providing healthcare insurance, they're just not going to be able to do that anymore because they won't either be in business or be able to afford that. So, any problem you can think of that's in the economy when it comes to business, it's worse for small businesses than for anyone else.
One more question from one of our attendees. Can you shed some light on the extent to which furloughed employees have returned to work? And I'll add to that sort of what the prospects are for more callbacks.
Right. As I mentioned before, a lot of the uptick in employment came from furloughed employees coming back as some states opened significant parts of their economy. Remember, 45 states closed down most, if not the largest part of their economy for in-person activities. So it's not just New Jersey and the New York metropolitan area, it was across the country. Then many of them have now gone back to being closed again, including 3 of the 4 largest states in the country. So this is why, as I alluded to before, it's not only difficult to project exactly what's going to happen because we don't control the pandemic, but it's also not a national response, it's a state response. And so each state is responding to its own conditions and changing its policies accordingly. So that's why I often say anytime you make a statement about this data, you're probably wrong by at least a week after that. But I don't see the next report being a positive one because I think many of those furloughed employees will probably permanently laid off as those businesses go out of business.
Okay, thanks so much, Carl. That sets the stage for our continuing conversation, why don't we go back to the slides? The other slide deck, please. Next slide. Thanks. So I just have a few more data points to share with everybody, just to really set the stage for the conversation with our panel of experts. So we're here to talk about the small group health insurance market, which peaked in enrollment in the standard plans at nearly 1 million back in 2005. It was a large segment of health insurance, source of health insurance for the New Jersey population. There's been an average decline of about 10,000 covered lives per quarter since that time. We'll show you a slide of that. There was a blip, and for families involved, more than a blip, when the ACA was implemented in 2014, which essentially moved groups without employees, the mom and pop shops, out of the small group market and into the individual market. We'll see those data. In the white paper that HQI put out, they have additional data, including this statistic, that the small group premiums have increased almost 40% since 2018, a major force involved in the coverage trend. And then again, of course, in 2014, subsidies became available for many people in the individual market, up to 4 times the poverty line, and that sort of changed the calculus for people looking for insurance. We'll also be talking about alternative markets to the state-regulated small group market, multiple employer welfare associations, professional employer organizations, and various self-insured level funding options that small businesses and others have. And we'll be talking about the implications of that. Notably, the first quarter 2020 enrollment data came out from the boards and for the regulatory boards, and for the first time, there are more people covered in the individual market than in the small group market. So this is a propitious moment to be discussing these issues. Next, please. So just a little bit of background at the highest level. So this is back at pre-pandemic, 2018, the most recent comprehensive federal statistics. And as you can see in the green, New Jersey has a larger share of people covered through employers. That has to do with the nature of our employment sector. We're a high income state, and those businesses are much more likely to offer coverage. And back in 2018, we had slightly lower uninsured rate, here shown in red, than the nation as a whole, again, largely because of the nature of our economy. Next, please. This drills down to just adults. That prior slide included children. This is non-elderly adults. And here we can see the trend in the number of people without coverage. So lower is good in this case. New Jersey has typically trended below the national average, and we continue to do so. Here you can really see the effect of the implementation of the ACA, which of course included the subsidies and the Medicaid expansion back in 2014. The nation has begun to tick back up in the uninsured rate. This is pre-pandemic. New Jersey has not. So we've been doing comparatively well before the catastrophe struck. Next, please. So just a little more background on the small group market. So this shows the offer rate. So the share of small employers, defined as 50 or fewer employees, that offered coverage. It's been trending down slowly. New Jersey does better than the nation, and just a hair better than our neighboring states, but the trend is clearly in the wrong direction everywhere. Next, please. Again, this is from the same data source. It's a federal survey, and here we see the premium trend 2008 forward, and we're going up just like everybody else. And of course, we're in a high cost market, so we're above the national average here. Next, please. So this is the slide with the crossover point that I mentioned earlier. The black line is the number of people enrolled, covered lives, including dependents and employees in the small group market. Now just over 300,000 at the end of Q1 2020. And the red line is the individual market, which has grown quite a lot. And you can really see the inflection point in 2014 caused a large one-time shift, but the trends have been ongoing for a long time. So before we leave this slide, well, one other thing I just wanted to mention, Q1, of course, is just through March. So this is really still pre-pandemic. It will have picked up some of the early effects in March, but I think when we see Q2 data, we'll have a much better sense of what the pandemic is doing to this market. So again, before we leave this slide, I wanted to throw out my first question to the panelists, and Linda, maybe you could take this one, or others feel free to chime in as well. Could you just sort of tell us across this whole time period that we're seeing on this slide, what you think has been driving the trend in these two marketplaces? Before the ACA, maybe during ACA implementation, and then in the current period.
Sure, thanks, Joel. Thanks for including me in this panel this morning. Before I answer the question, I think that I just want to highlight one point that was in our paper that I think we can all agree upon, is that we're all a little bit struggling and guessing because we don't have the actual data. And this actually, I got the opportunity to listen in on the small groups public meeting yesterday, and this topic came up there as well, that we would be in a much better place as a state if we actually had the data, specifically knowing exactly where all of the individuals that were in the small group market specifically had gone, whether it's to the individual market or Medicaid or some of the other options that are out there. And we don't have that data today. So that's definitely one of the recommendations in our white paper, is for the state to have the ability to have that data reported to it to inform decision making. But I think that all of the reasons that were mentioned, and I'll just go into a little bit more detail, is really what was going on. The small group market traditionally had a large percentage of the small group market was these so-called micro plans. So it was plans that were under 5 and many were under 10, and many were actually under 5. So it was a family that ran a business that was purchasing for themselves, and then were shifted into the individual market. The Great Recession obviously had a big impact on employment, and that translated into a loss of lives. And I think it's a combination of the attraction of subsidies in the individual market, making those plans just a lot more affordable for people that are under 400% of the federal poverty level, and the new options that are out there, or newer options that are out there in the small, as an option to small group, whether it's the level funded plans with a stop loss, which I know we're going to talk about a little bit more, or MIWAs, or the PEOs. It's just people, it's all about price for these markets, and employers don't have a mandate. So they're looking to, how do I do the right thing and provide insurance for my employees, but, you know, watch every dollar as I do so.
Great, thanks so much. And as we proceed, maybe we can talk a little bit more about those data blind spots that you refer to. It's important to note that the small group market data shown here is just the regulated market, and there are alternatives available that we don't know that much about. I will give one little promotion plug here. We at the center just posted a paper that looks at how people transitioned from pre-ACA into ACA coverage, and we can add that link to the distribution. It's not on the list now, but we can add that link when we distribute, sort of after the panel today. It doesn't get into who's going into Medicaid and other things, so it's limited, but I think informative. So let's advance the slide, please. There we go. Okay, now we're formally in the question and answer period. And again, reminding folks to post their questions, which I will turn to at the end of sort of my prepared questions, or squeeze them in if I can in between, if they're germane to the topic that we're on. So I want to turn to questions about the stimulus money, the CARES Act funding, and maybe Carl or Chrissy could address this. That was a lot of money. A substantial chunk was directed to helping businesses, the PPP. How have New Jersey small businesses, small employers taken advantage of that? Has it supported them? Where are the remaining gaps?
I could certainly jump in here, Joel. So thank you, and thank you to Rutgers and everyone for the opportunity to connect with you all today. As mentioned, I work with the New Jersey Business and Industry Association, and we represent the smallest employer up to the largest in the state of New Jersey. And certainly, this is a very timely topic for us, right in the throes of this pandemic. And again, as we know, we're in a healthcare pandemic right now, and the safety of our residents is paramount, but also the small employer community has been facing a tremendous amount of challenges that were alluded to through the previous presentations that Carl went through. In terms of funding resources for our small employers at this point in time, I can start federally and then transition over to the state. But through July 10th, New Jersey received just under about 150,000 loans totaling about $17 billion. So that's about a 16 to 17% of those eligible received loans. Additionally, we received, and those were PPP loans. Additionally, about 75,000 received EIDL loans totaling just under $5 billion. So when all said and done, just about a quarter of our eligible businesses received federal funding assistance. So clearly there's a lot of need out there, and there is even greater need than what these numbers indicate. So that's what New Jersey received so far federally in terms of the major funding programs. On the statewide level, if we go back in history also a little bit, the New Jersey Economic Development Authority did put out 2 different tranches of funding. One was put out basically off their balance sheet, and those grants and loans went out the door almost immediately. And so that total about, I think it was about $10 million, I'm sorry. And then going into the second tranche of money, there was an appropriation through the Federal CARES Act that appropriated about $50 million. And again, those programs have been oversubscribed substantially. So both on the federal and state level, our New Jersey small businesses have been impacted a lot. They are struggling to get their doors open. Even if they are open right now, they're not all operating near capacity from what they were doing pre-COVID. So the numbers are staggering at this point in time. And again, with the states kind of going backward in some cases, hopefully we can stem that tide and make sure that we can all safely reopen, because it's really critical to make sure that the employers are open safely and that employees are able to come back, per the discussion earlier about New Jersey's unemployment rate.
Thank you. That's helpful. Clearly a lot, and clearly not enough, I think is the answer. Yeah, you're right. So Carl got into this a little bit at the beginning, but are there other things that folks can add about sort of which small employers or small employer worker communities might have been disproportionately affected by the pandemic?
again, I guess I could jump in, but I think Carl
Please
did
do.
allude to a
Yes.
lot of this already. I mean, again, businesses with 50 or fewer employees did see the largest decline in employment through April. Our leisure and hospitality, as Carl mentioned, probably took the largest hit, followed by trade and transportation. We're talking significant numbers here. Certain counties in New Jersey, again, had a real concentration in North Jersey that was hit harder. So we definitely are seeing a difference between where we're located in the state. And also our minority and very small businesses were hit disproportionately as well. And so as we focus now on trying to get into the recovery efforts, it's going to be really critical to focus a lot of those efforts on Main Street and on our minority and very, very small owned businesses.
Yeah, thank you. Thank you. I think we
Joel,
suspect that, but yes, go ahead.
Joel, just adding an example of what we're seeing, even in New Brunswick with the announcement last week that Rutgers is going to be basically virtual for first semester. So think about the impact in New Brunswick of the small bodegas, the little restaurants, the takeout, all of whom rely on 30,000 students and faculty, and having this influx of customers come August and September, and that's gone. That's going to be gone for all
Yes.
intent and purposes over the fall. So think about community like New Brunswick, right? Obviously in our backyard, and the impact.
Yes, yeah, true enough. Just one comment from someone from the broker community who added through the chat that just to emphasize that employers are really struggling with the PPP loan program, its implementation, getting answers, particularly around loan forgiveness issues. So I don't want that to get lost in the process as well. So let me go on to the next question. So as those who follow this closely very well know, there is a health insurance assessment on New Jersey's regulated health plans that will be imposed. My understanding is it mostly just replaces the assessment that the feds had and then dialed back on, raising $300 million or more to promote stable and affordable coverage in the state. It's expected to provide relief mainly in the individual market through subsidies and the reinsurance program. My question is, and maybe this goes to Ward, is what does that do to the small group market? Does it create an attractive option for small group employers or employees in any way?
Yeah, thank you very much, Joel and Margaret and folks at the Rutgers Center for State Health Policy. You guys are a trusted voice in healthcare, and really just want to say thank you for all the work that you've done in studying healthcare in New Jersey and removing some of those blind spots that that policymakers and stakeholders are working on. So, well, first I wanted to talk just to correct a little bit the nature of this tax. So, while I think it was conceived as replacing a federal tax, as drafted anyway, there are certainly significant differences in the state tax compared to the federal tax. The bill, for those of you keeping score at home, is S2676 and A4389, just recently introduced, and some rumor that it may be heard as quickly as next week. So it is a 2.75% tax on premium of just about every type of premium in New Jersey that can be taxed other than Medicaid. The federal tax did reach to Medicare Advantage and Medicaid and some other lines, but this also would reach to Medicare Supplement and some other lines of coverage that the federal tax did not. So, you know, in our view, this is really going to hurt small businesses, local employers that are already struggling in a very difficult time in the time of COVID here. You know, as you've heard from Carl and others, these mom and pop shops are really struggling. The average size group in the small group market, last time I checked, was under 5 employees. And while carriers have tried to provide relief through grace periods for premiums allowing folks to be furloughed and still can be considered eligible employees and so forth. There's no question that this is going to be a really, really challenging time for employers. And the bill really does target the individual market for the revenue that's generated. I think further exacerbates the problem that we've seen in the small group market. The Kaiser Family Foundation estimated the average premium in New Jersey was about $22,294. So at a 2.75% tax rate, that's going to be an increase of $613 a year for a family. Just to give you a sense of what that means, it also taxes the individual market. I actually went online, and for me, the coverage ranges, the lowest premium was for myself at age, and my wife age was $22,956 a year. It was the cheapest plan. The most expensive plan was $40,596. So just based on the tax alone, you're starting in the hole. You know, for me as a family, $631 to $1,116. Very concerned about the impact on cost in these markets. I'm not quite sure. It doesn't appear to be any relief for mid-size employers. I'm not sure what relief there is for small employers. And I think this is going to be a really hard hit, this health insurance tax on these folks. I think you'll further see a decline in the small group market as a result of this, should it pass, and certainly in its current form. It also is going to impact Medicare supplements, so it's going to impact older folks in the current draft anyway. That it does reach to that. So there's sort of significant concern in the time of COVID to be taxing health insurance, which again, we're a mandate state, so we're taxing something that we're requiring folks to have. Very different than a luxury tax or a sin tax. This is actually something, a service and supply that we actually want folks to buy. So a difficult time to do that.
Sorry, have to unmute. I think Elena Kagan did that in a Supreme Court hearing, so I'm in good company.
If I could also just chime in.
Yes, go ahead.
From a small employer perspective, again, I want to echo, some of the comments made by Ward. Excuse me. NJBIA has always surveyed our membership and has always found that offering health insurance is a really, really key component, for our employees. And over the years in our survey results, the rising cost of health insurance is a top concern. And I know you can all see the data that a lot of insurance is offered by the employer community. And so when we have challenges that we're talking about, such as the decline in the small group market and proposals that may have an adverse impact on that small group market, it will be challenging right now to have another cost increase going on top of these employers especially at this critical time. And so I just wanted to add what Ward had mentioned, but obviously want to, continue to look through the legislation, et cetera. But it is going to be very challenging to put any additional costs on the small employer community at this time.
Understood. Thank you. So we have a request, Ward, for you to repeat the bill number.
Sure. So the bill number is S2676 in the Senate. That's been referred to Senate Commerce. Maybe heard it. There's the next, I think, committee meeting is the 23rd of July. The Assembly bill is A4389. There's an Assembly Financial Institutions and Insurance Committee meeting also on 7/23. I think the agenda just came out, but I haven't seen whether it's on there or not.
Good. Thank you. So a related question from a participant. Does the insurance tax apply to nonprofits? I think the answer is yes. It's any insurance purchaser, right?
Yeah, so the tax at the federal level, if I remember correctly, was crafted differently. I think that there were special there were differences depending on the licensure of the carrier as to whether they were profit or nonprofit. That distinction is not translated into the state bill.
Okay, thank you.
Purchaser, it's irrespective of that. Yeah.
So the answer is yes, it does apply. So just one more follow-up question on this topic, and then we have so much to cover, I want to move on. And that is, you know, clearly, Chrissy, Ward, you've made the clear case of the pain that a tax can impose. And of course, nobody ever wants taxes, and taxes do distort markets, and you've articulately explained how that's operative here. But it also generates a lot of revenue, and I don't want to lose the question about what the uses of that revenue can do to either support or otherwise not support the small group market. Again, it's the money is mostly going to go to support, as I understand it, the individual market, perhaps enhanced subsidies, and certainly the reinsurance program. But to what extent are those investments going to have implications for the small group? I'll open this to anybody.
Well, I'll jump in. This is Lynn. Originally, I think the idea was that this tax would be imposed against in all markets, including the Medicaid market. And by doing so, the state would be able to raise, I don't have the numbers in front of me, but I think it was about 150 to 200 million actually in federal funds. And the idea would be that it would be a source of income that could be used to support the individual and the small group market. The bill, for various reasons, no longer includes Medicaid. So really, other than taxing our existing markets, the only federal funds that we're getting by imposing this tax is, my understanding is, it's about 57% of the tax that's being put on the individual markets actually going to come from the federal government, because it subsidizes that market in part, you know, for people who are under 400%. So we are making all of these markets more expensive by imposing a tax. I don't think that that's debatable. There is a benefit to the individual market because the funding is going to go to, in part, to support the reinsurance program, which brings the overall cost of premiums in that market down, hopefully thereby bringing in healthier lives, making that a healthier market, a more affordable market. But for the other markets, for the small group, for the large and the other ones that are in the bill, I think the bill, the last version I saw, included MIWAs as well. There is not additional specific, I don't see that how the magic wand works where you tax something 2.75% and then thereby through something else, you're going to make it more affordable beyond that amount that you've just taxed it. And so I think it's more of a hope than a reality. Maybe the funds could be used to support specific individuals with subsidies within those markets, but overall, you're not making those markets more affordable. You're just making them 2.75% more expensive.
Great.
If I could add one quick note there, Joel, if I could. I think some of the thought is to subsidize additionally folks at lower income levels, which is certainly a noble goal. You know, having a external subsidy is always, you know, the federal government or some external subsidy is always better, because that truly does make health insurance cheaper. But for folks above 400% of the federal poverty limit who are taxed, like the numbers that I gave, you know, if they're not envisioned in any kind of subsidy, this is just that's going to increase that segment of the market. You know, family of four at $4,000 doesn't necessarily feel wealthy, and the notion of paying another $1,000 for their coverage is not making the individual market certainly more affordable for them. That, I think most folks agree that the loser class in the Affordable Care Act are those folks above 400% of the federal poverty limit.
Yeah. Okay. Thank you. So let's move on to other topics. We could spend the whole time on this, no doubt. There may be some other opportunities to stabilize this market, and I want to sort of bring those up. So, Peter, I may ask you to jump in on this one. What are the implications of the new health or insurance coverage health reimbursement arrangements? It has the unfortunate acronym of ICHRA.
Right.
Could you tell us about what that is and how that might offset premiums in the market segments that we're talking about today?
Sure, Joel, happy to. And thanks to my friends from New Jersey for including me in this. So these ICHRAs, it's a major shift in federal tax policy. For the first time, an employer group can organize a group plan that's based not on coverage, but on providing an HRA, which the employees can use to actually pay premiums on individual coverage, as well as out-of-pocket costs. It was a major initiative that Trump announced with his executive order shortly after his inauguration. It's too early to tell where they're going. The Trump administration promulgated the final rule in January of this year, so they missed that sort of important November, December enrollment cycle. Certainly there's some compelling financial reasons why they may be attractive to employers. It's the same reason why that many of us have 401ks instead of pensions. You know, it's sort of a defined contribution rather than a defined benefit. And you can duck those annual double-digit increases in coverage. Although the Trump administration regularly trashes the individual market, the markets are so vastly improved from the way they were 2013 that there just would be more hospitable for someone that's in the employer-sponsored market now. And, you know, after years and years of increases in cost sharing and premium contributions, ESI may not be as attractive to some people now as it was 20 years ago. That said, you know, when I talk to some people, you know, the consensus is that these ICHRAs are more likely to be kind of a niche market. There's a couple of issues. One question is, so, and Christy might have some thoughts about these points, but if you're an employer group that left the small group market, just couldn't afford it, you know, washed your hands and said, look, I can't do this anymore. I'll try to increase your salary to make up some of the distance. Does this get you back in? A second issue is, you know, to the extent that one of the reasons employers pay for health benefits is to attract and retain valued employees. Is there, you know, replacing a comprehensive group plan with an individual plan going to have the same effect? Obviously, there's differences in the individual market. Might have a narrower network, or you might not see the availability of out-of-network benefits. So that's certainly an issue. Third, these things are remarkably complicated. For such a simple idea, you get involved in ERISA, IRS Section 125, the employer mandate, major new responsibilities for individual employees who sort of have to navigate their way through this affordable test, you know, on their own, basically. So, you know, there's plenty of people out there that are, you know, marketing these services, but they're complicated. And the way it's set up, they sort of move the ERISA class definitions over. So, and I think that was the right call, but an employer can't have a comprehensive group plan for, say, management and ICHRAs for, you know, like say the hourly employers. So they're being aggressively promoted by CMS. They have webinars every week, and there's plenty of material out there. They're projecting over 11 million enrollees in the individual market with ICHRAs in 10 years. But they also project a drop of 7 million in the ESI market as some employer groups switch from full coverage to ICHRAs. And they also project a $6 billion drop in premium tax credits. And I think that's sort of another issue. I mean, I think this puts employees that are in the individual market receiving tax credits, I think they're somewhat at risk, because even though under the this
Good point.
affordability test, the coverage is affordable, they might be getting a better deal with the premium tax credits. So too early to tell, but we'll see how this unfolds.
Yeah, thank you. And with someone from the broker community added a comment that sort of all the requirements of the ICRAs are a real turnoff, and I think you touched on that. It's not a simple thing.
Well,
So
I was on this webinar with this team from CMS that's promoting these things, and you know they have like tax lawyers and ERISA lawyers and a whole group of sharp people. But we ended up getting in a 5-minute conversation about whether an ICRA was covered by COBRA. And the answer was yes, you had to notify an employee of their eligibility for COBRA. But if they opted in, they would have to pay a monthly premium that was essentially equal to the value of the HRA. But you had to give them that opportunity. So there's a lot of complications.
right. Yes, it's the Full Employment for Lawyers Act, I guess.
Right.
So, no offense to the lawyers on the caller. So it does highlight, and there's another comment in the portal that employer-based health insurance is really an accident post World War II, and that it just fits the small groups so poorly because it is so complicated and has all these sort of transaction issues, and you need a lot of expertise to navigate it optimally. But I'll leave that as a comment. Let me move on to the next sort of big topic. So the small group market, the ACA allows for the merger of the small group market with the individual market into a single risk pool. We at the center sort of reviewed this issue way back before ACA implementation and sort of concluded that it didn't make a lot of sense back then, but times have changed, to say the least. And I believe at least Massachusetts merged. I don't know if New York did. I open the question to anybody about feelings about whether there's opportunities to help stabilize the small group side through a market merger in some way.
I'll try to kick us off very briefly here. Just the small group market exists because they have special challenges. I always think of Willie Sutton. Why do you rob banks? Because that's where the money is. It's true here in the small group market is like this is where the uninsured come from. Nearly, almost all large employers offer coverage. Smaller employers offer at much lower rates, as the original slides showed. Where you put those boundaries matter. New York, and I'm sure I could speak to this much better, goes up to 100. I don't think you've merged the individual market there. Massachusetts, as you noted, Joel, does have a merged market. And it's constantly a part of a dialogue in these states as to essentially who you're grouping together. And you generally have one group that may favor it and another that disfavors it. I think part of the dynamic in New Jersey had always been that the small group market, which had probably a better risk profile than the individual market, would effectively be subsidizing the individual market. I think in New York, the 50 to 100 probably subsidizes the 1 to 50 in some ways. There's some cross subsidies. So I'm not sure what the right answer is, but this is constantly evolving. A small group is now smaller than the individual market. So it's challenging to pin this down at one time just because these market dynamics change so drastically. So again, I'm not sure if it's a good idea or a bad idea, but I suspect there will be winners and losers, and we'll hear from them both if we.
For sure, you can count on that. Other thoughts from others on the panel?
I'll jump in. I know it was a while since you did this study, Joel, but I think not to put work on the center, but I think a new study and modeling. I think the timing is right for it, and I think it would be great to see, to Ward's point, looking at a couple different options. So really piecing that question out. Does it make sense to merge groups of, say, under 10 with the individual market, and then to have the small group go up to 100 like what New York does? I mean, or to leave it up to 50, just a couple a couple different variables. I think, you know, in our paper, we talk about some changes for taxes in the small group. And I think that should be looked at with respect to the merger too, so that we could give, I mean, small employers are able to provide these benefits and not have it be considered income to their employees. Individual market, it's all post-tax dollars, it's income. So is there a way to adjust that in some way for small employers? I think, you know, there's a lot of different pieces to it, but you know, certainly with the numbers going in the wrong direction and New Jersey being a state of small employers for the most part, I think that these are really important issues to look at.
I think Linda just volunteered to fund a study, by the way.
Yeah, that's great. So you mentioned, I'm sorry, go ahead, Chrissy.
I also just wanted to you know, mention as well, and I think some of the points were certainly articulated about, you know, there could be pros and cons, and certainly want to make sure that the small employer community, you know, is protected because they are not subsidized, and there are differences between the individual market and the small employer market. And, you know, we need to make sure we understand the experiential ratings and such. And so, you know, some sort of an actuarial analysis will certainly, you know, need to be conducted. But I do caution folks that, you know, we haven't seen the dust settle from COVID yet either. And so, you know, I think that's an important component to all of this, as we're still really in the midst of, you know, trying to get ourselves out of a healthcare crisis as well, to see where everything, you know, comes out on the other end. But, you know, certainly we just want to make sure that our small employers are able to continue to offer this benefit, and make sure that whatever, you know, policy is contemplated keeps, you know, the employer community in mind.
Mm-hmm. Yes. Linda had mentioned or maybe Ward, or maybe both, that we also have the option of expanding the definition of small group up to 100. And Peter, maybe you could address that. I know that's something New York did, and could you talk about the implications of that? This maybe with your mute off.
That would be better, wouldn't it?
It would be, yeah.
So yeah, we're one of the few states that did it. We were somewhat fortunate in that when we adopted the overall ACA implementation in 2013, we included the small employer market change size in that law, and then just made it effective in 2016 when the ACA change actually kicked in. So during that time when there was transition relief and states were being signaled that they didn't have to do it after all, there was we already had it on the books. So it became a matter of having to repeal something that was in law rather than enacting something.
Right.
As the date got closer, there was, you know, there were some employers that sort of renewed coverage before the deadline so they could get like an extra 18 months out of an experience rate. There was some pushback from the legislature about repealing it. Ultimately, it survived, although there was a compromise with some of the 51 to 100s that had stop loss arrangements already in effect. So some of those groups were grandfathered. So, you know, I think we did it for good reasons. You know, our small group market is probably more trouble than yours, actually. I'd hate to see what it would look like if we hadn't done that 51 to 100 change, but you know, it was contested, definitely.
Mm-hmm. Mm-hmm. Okay, thank you. That's very helpful. Lots more topics I want to get to, and I'm mindful of the time. Just a couple more from me, and then I'll try to draw in some more of the participant questions. Let's turn to the alternative markets question. I know this is a huge one. There's MIWAs, there's PEOs, association plans. How do these affect the viability of coverage among small employers? And I word that carefully because it's not just about the regulated market, it's about the whole market. Does it lead to risk selection problems and other kinds of things that just are a weight on the efficient functioning of the market for this segment. I'll open that to everybody because I know there'll be a lot of thoughts. Maybe
Joel,
not.
I'm happy to kick things off if you like.
Yeah, please do.
It's the alternate markets are a big problem in New York, and New York is a state where we've had insurance regulators that have been very proactive on these issues for decades. Our state AG is actually leading the charge against the Trump administration's Association Health Plan rule. So despite those efforts, there's been a steady drain of small group coverage into these alternative markets. PEOs have, it's sort of entered through the back door through an amendment to the New York labor law rather than the insurance law, have drained large amounts of covered lives from the small group market. It's very hard to quantify. As a policymaker and a regulator, it's easy to sort of see what's the best policy for, a market or a risk pool or a segment. You want a broad pool, so risks are spread, and you want everybody playing by the same set of the rules. But, it's hard to, implement that policy without creating winners and losers. And the losers can create a lot of racket, and they'll exercise their rights to go to their lawmakers, and often, with the assistance of the sophisticated sponsors of these types of arrangements. And, that's a conversation you have to be prepared to have. Like the Cuomo administration tried to close that door on the PEO window, and by submitting legislation, and it was rebuffed by both the Democratic Assembly and the Republican Senate at the time. The other thing I'll say is that this is a very tricky area to regulate. It's complicated, in some ways your hands are tied by ERISA, but, it's activity that's just sort of, I liken it to be like being in a forest with a nice roaring campfire at night, so you can see everything around your campsite, but outside the ring of light, you'll see like eyes glowing in the dark or a rustle in bushes. And it's PEO sponsors, it's AHP sponsors, it's benefit consultants, it's brokers, it's MIWAs, and they're out there scrambling around trying to get, the best deals for their clients. And it's really hard to tell, who they are and what they're doing. So it's very challenging.
Yeah. I'll open it to others for comment, but I'm particularly interested on the data blind spot question. If a famous New Jersey resident once said, if you don't know where you're going, you're likely to end up someplace else. And I know that the state doesn't get all the regulators don't necessarily get all the data they need to know what those eyes are peering in. But on that or any other questions about the alternative markets, the floor is open to the panel. Nobody has opinions. Okay.
I
Well,
will just chime in briefly. I know this is one of those, certainly a complicated matter, as Peter did allude to. And again, from a BIA perspective, we have employers who utilize all these markets. I mean, we don't have a single payer system, so that's what happens. Some of the things, I think it's just important, without getting into the intricacies of each one of them, that you acknowledge that they are regulated or not regulated at all, and that is different. So just lumping them into one category, I don't think is the appropriate way to go. For instance, there's only 2 approved MIWAs in the state of New Jersey, one of which NJBIA participates in. That's been around for over 40 years. And so it's not a new entrant into the market by any stretch. Also, it serves a very niche market, which is those very, very, very small employers. And that's also a place where the employer community, has a role in making sure that, that they're abiding by all DOBI regulations and such. So I think it's just important to understand what the nuances are in all those different markets that were mentioned, and not just lumping them all together. Certainly, we don't know where everyone's going for each one of them, but I do think that understanding how New Jersey regulates them, for instance, association health plans are not permitted. You have to be an approved MIWA. There's two. You know, it's just an important caveat to understand when you're discussing other markets besides a small employer market.
Thank you. Linda.
Yeah, I'll chime in too. I appreciate and totally agree with Chrissy's point about the MIWAs and the fact that they're co-regulated, so they have to apply with both Department of Labor as well as New Jersey's requirements. And we addressed the whole issue of the level funded plans and the stop loss in the white paper that we put out. I think that it's just important to remember that employers in this market, you know, there is no mandate on them, so they don't have to offer insurance. The ones that do are trying to do right by their employees and are looking for affordable options. And I think we've talked about for a while, you know, this morning, you know, all of the struggles that that they're dealing with in trying to do that. So that's why the suggestions that we're talking about are really, they all have to fit together. It's a comprehensive approach. Just getting rid of stop loss isn't going to miraculously make this market better. We have to be thinking about a whole package of changes to improve this market. But I mean, that's definitely one that should be on the table. And I think it's, you know, I think it's a very fair thing to consider when you don't have a level playing field. Obviously, you're going to have adverse selection, and that's just a principle of the insurance markets.
I'll get it right, yeah. Thanks so much, Linda. So we only have about 10 minutes left, and I just want to make sure that we can get to some of the questions from our the attendees, and I'll try to lump some together in the interest of time. So one asked, this is again back to the tax. Are you saying that it would be passed through from the insurance provider to the premium payer? I think the answer is yes. But let me bundle something else here. Is the statutory incidence, is the tax imposed on the purchaser of the plan or of the issuer of the plan? And if the issuer, is there a way to sort of mitigate the ability to have it filter down into premiums?
Well, as a matter, yeah, the bill addresses the issuer. So a tax on premium, just as the federal law is. The federal tax, and again, they are different, but the federal tax was repealed on a bipartisan basis because, like any other, whether you're, you know, if you tax butter, the dairy is going to increase the cost of butter. It is you know, it's just I think is a likely result from this. And you can see this in the rate filings. The federal tax was frozen for 2 years, and the rate filings from the carriers reflected that the tax was gone, and then it came back, and it you know, it came back in. So yes, tax on the issuer, and I think a very strong likelihood that it passes on premium.
Yeah, unavoidably so. So another comment or question from an attendee, really reflecting on the group size discussion we had a minute ago. When two contiguous states have different sets of rules, it can cause problems. Margaret, do you want to, as a board member, you want to chime in on that?
Sure. You know, I think the you know, the idea that the inconsistency of looking at the regulation, and we know that New Jersey is kind of pinched between, and the transition of markets in New York and Pennsylvania. We know that from the healthcare system, people move and certainly get their healthcare in different states. So the fact that regulations change in border states has an impact. And certainly, I think as Peter distinguished, the group size differences in New York and New Jersey, and kind of heartened or disappointed to hear that even New York is in worse shape than New Jersey. You know, harmonizing any kind of regulation and activity for regulation, I think is the efficient way to go.
Yeah. Always easy to do, right? Think about the Port Authority.
It's easy to say. It's hard to do.
That's right. Let's see. One quick question. An attendee is asking how much revenue we've been raising from the mandate, the tax on people who fail to, adhere to the mandate.
Yeah, I can take a shot at that. So the IRS has publishes data on the individual mandate payments by state. So in 2016, 17, and 18, it was close to $100 million. I've heard that the state is anticipating, as it shifted here, only revenue of $30. So, one of the reasons for the tax that I've heard anyway, this new tax that's being proposed, is to help fund reinsurance. But we seem to be $62 million short from, I think, what folks were expecting through the tax. So I think there's some questions there as to what happened. Not as if more people were, covered or eligible for exemptions. You would not think anyway from the data. So I think it's sort of a big question mark there. But that's how much they were collecting at the federal level. The taxes, because as I just remembered 2 days ago, got extended only to the 15th, but we did have extended taxes. So the state is still collecting the revenue at this point.
Yes. So we'll look for those numbers in a few months, but it does sound like we're below target, or at least projections. So another question from the group. So New Jersey is standing up its own health insurance exchange, and so already taking over some functions, and next year we'll have our own exchange. What are the implications of that for the small group segment, if any?
I'll start out, Joel. I think that the state's number one priority has to be a successful launch this fall of the new state-based exchange. And I fingers are crossed. I sincerely wish them well on this, because I think once it's launched and it's available for individuals looking into the future, it does offer a lot of potential opportunity for the small group market and the state as a whole. I think other states have shown us that having harmonized approaches to purchasing can make a real difference. And I'm thinking of California in particular. They're putting in quality requirements in the plans that sell on the exchange. For instance, when it comes to maternity care, they want to have their networks. They want to have hospitals that meet the C-section rate, for instance. So I think once you have a functioning exchange, you can expand the open enrollment dates, and then you can start putting in quality measures. You can start putting in decision tools for individuals as well as small groups to look at when they're doing their purchasing. There's a whole host of opportunities, but those are all blue sky down the road once we have a successful launch, which I know we will, and we're rooting for that.
Joel, could I just chip in here?
Just very quickly, we have about 2 minutes.
Okay, as a proud New Yorker, I'm so pleased that we have our own exchange, and it does so many wonderful things, including extending the special coronavirus open enrollment period to now August 15th, and setting up this team of navigators, very skillful people across the state that are helping all these individuals that have been harmed economically or lost loved ones and lost their coverage, And these experienced individuals are helping these people sign up for coverage. And it's really terrific to see.
I think that's a lovely way to end. We were looking for a positive note. I will say that I saw, was it yesterday or the day before, Adobe announced that they're looking for proposals for navigators. It's so we're getting there. We're getting there. So I want to thank the panel. This was really quite rich. I wish we had another hour, but we don't. Margaret, you want to wrap us up?
Sure. Yeah, just echoing Joel's thoughts and gratitude to our panelists. We had about 100 people, 102 people on the call, and most people stayed. So hopefully that was an illustration of people felt that the conversation was valuable. Oliver, if you just go to the next slide, please, that final slide, if you would. This is the resources that we talked about. We have the link to the white paper that the Quality Institute produced. And Christy shared the links for the surveys, for the DIA surveys. Invite you to take a look at the recent the findings from the outreach to her members, as well as the material that Carl had mentioned. I'll also put a plug in that we're going to continue this series. We'll keep you all on the mailing list, so please look if you're interested in other topics. And finally, if you would kindly fill out the form that you get from Zoom at the conclusion of this webinar. So again, a warm thanks from all of us. It was great to talk about something that, I think is important to all of us, looking forward and planning for the future. And we just wish the best for all of you and your families over the next few months. So everybody stay well and take care.
Thank you.
Thank you.
Thank you, guys.
Thanks, Margaret.
Bye-bye.
Bye-bye.
Take care.